Hi, and welcome to our TED Talk on mucopolysaccharidosis type 1. I'm Tim.
Hi, I'm Madeline.
Hey everyone, I'm Connor.
Hi, I'm Emily.
Hey, I'm Victoria. Let's get started. Take it away, Tim.
To start with, mucopolysaccharidosis type 1, or MPS-1H as we will refer to it from now on, is an autosomal recessive disorder characterized by insufficient production of the IDUA, or the alpha-1 iduronidase enzyme. This deficiency prevents degradation of glycosaminoglycan, aka GAGs. As GAGs keep accumulating, neurological and physiological components such as organ enlargement basically, joint immobility, skeletal diseases, and respiratory issues will often occur. Furthermore, it can cause delayed developmental milestones and cognitive deterioration for those who are undiagnosed. So as we can see in the picture, inherited gene mutations lead to enzyme deficiencies in the garbage dump of the cell, otherwise known as the lysosome. Since the lysosome can't break things down, GAGs end up building up in the body cell in the central nervous system. This causes a disruption in homeostasis and is the clinical onset of MPS-1. MPS-1 is diagnosed using clinical examinations to assess cognitive disabilities or physical abnormalities, excess urine and GAGs, and blood analysis to detect deficiencies in lysosomal catabolism. This disease affects about 1 in 100,000 births in the United States, and patients have an average life expectancy of 10 to 20 years. Due to the nature of the disease, debates and treatment methods revolve around providing the most optimal treatment to both prevent symptom onset and reverse manifestations of the disease that are already affecting patients. Common treatments include enzyme replacement treatment, also known as ERT, hemostatic stem cell transportation, or HSCT, and hematopoietic stem and progenitor cells, also known as HSPC gene therapy. So ERT works by increasing GAG catabolism to increase the IDUA levels. HSCT is a single transplantation from a healthy donor to slow neurological deterioration in the recipient, and HSPC gene therapy involves using a vector to place modified HSCT within an individual with the purpose of improving neurological and skeletal symptoms of MPS-1. Current standard treatment involves a combination of ERT and HSCT. However, ERT and HSCT proved to be insufficient. The novel approach of gene therapy as a potential avenue for continued research proves to be the most promising treatment method yet.
One treatment used now is enzyme replacement therapy, or ERT. By delivering the IDUA lysosomal enzyme into the blood, GAG catabolism increases, cellular function improves, and the clinical onset of Mpsi-H is delayed. While ERT is extremely effective in treating somatic symptoms of Mpsi-H, as shown by the decreased GAG levels in urine, increased joint mobility, and improved pulmonary function, it fails to address neurocognitive, cardiac, and skeletal damage. This is due to ERT's inability to penetrate the blood-brain barrier or reverse neurocognitive damage. Other limitations of ERT include that it requires frequent administration of the IDUA enzyme as a result of the enzyme's short half-life. This translates to frequent hospital trips and an increased risk of infection, leading to high patient expenditures and a decreased quality of life. Additionally, antibody accumulation in the form of high-titer anti-drug antibodies was observed over the course of ERT treatment. In studies, this was associated with worsening physical performance and a decreased response to treatment. Furthermore, elevated biomarker levels indicated residual disease activity in response to long-term ERT treatment. This correlation between increased antibodies and a decreased physiological response suggests that the efficacy of long-term ERT treatment actually decreases over time. Patients might need to undergo immunosuppressive therapies prior to receiving treatment. Well, even though ERT is insufficient as a standalone option, it can be used as a bridge therapy until HSCT can be performed. In the picture on the screen, the starburst diagram shows that ERT's limitations necessitate modifications to standard treatment or the development of a new therapeutic technique.
Now that we've learned about how enzyme replacement therapy on its own is insufficient, let's talk about another treatment option for MPS-1H, allogenic hematopoietic stem cell transplantation. This treatment, with the addition of ERT, is the current gold standard for MPS-1H. Allogenic HSCT is the transplantation of healthy donor hematopoietic stem cells collected from bone marrow, peripheral blood, or umbilical cord blood to a patient with MPS-1H. Healthy donor cells secrete enzymes that are taken in by the recipient's own IDUA deficient cells through cross-correction or the transfer of functional enzymes into adjacent defective cells. The efficiency of HSCT can be affected by many factors, including age, disease progression, the type of donor cells, and preparative regimen used to prep the cells for transplantation. HSCT has some important and meaningful benefits, such as slowing disease progression and improving cardiopulmonary function, hearing, and vision. Most importantly, however, HSCT can halt neurological deterioration in children. That is why the earlier it is performed, the better. HSCT works to decrease neurological symptoms of MPS-1H by penetrating the blood-brain barrier and secreting IDUA to enzyme-deficient areas of the brain. Although HSCT does have many benefits, it is not void of insufficiencies. There are many limitations to this treatment, including its inability to reverse pre-existing cognitive decline, musculoskeletal disorders, or cardiac diseases. Not all manifestations of MPS-1H can be treated by HSCT. Therefore, another treatment method is needed.
In order to target the central nervous system, particularly the brain, ERT must be modified a bit. In recent years, scientists have begun inserting an immunoglobulin or IgG domain onto the standard IDUA enzyme. The IgG domain is a receptor-specific antibody that attaches to the insulin receptor on the blood-brain barrier, allowing the enzyme to cross into brain tissue. The downside to this method of treatment is that it involves frequent invasive procedures and poses high surgical risks involving the implantation of devices that deliver IDUA into the cerebrospinal fluid. Other modifications are being explored to improve the standard treatments of Mpsi-H too. Currently, immunomodulating techniques or immunosuppressive methods are being studied in response to increased antibodies and decreased cellular uptake of the IDUA enzyme in Mpsi-H mice from long-term ERT treatment. Anti-monoclonal antibodies like anti-CD4 are administered in 2 regimens to suppress the immune system and eliminate antibody response to IDUA in mice. This increases the efficacy of ERT and has the ability to reduce graft versus host disease in allogenic or donor-derived HSCT. Also, immunomodulation could alleviate immune responses for future protein and lentiviral gene therapy products. Since Mpsi involves organs such as the brain, heart, and lungs that are susceptible to regimen-related toxicity from the preparative regimen used on transplanted cells, Mpsi patients exhibit greater vulnerability to toxic conditioning regimens. Actually, one procedure used a reduced intensity paratransplant or before the transplant conditioning regimen to promote immunosuppression and decrease toxicity. This regimen was well tolerated and associated with a low incidence of regimen-related toxicity. To confirm these results and further explore reduced regimen-related toxicity in Mpsi-H patients, larger studies will need to be conducted.
As we previously discussed, ERT and HSCT have benefits, but they don't alleviate all symptoms and manifestations of MPS. A new treatment modifies allogenic HSCT by administering ERT in the pre- and post-transplant period as a supportive treatment to improve patient conditions and outcomes. When ERT is delivered peritransplant before HSCT, it improves pulmonary function and the clinical condition of the patient. This combined treatment method decreases transplant-related complications and MPS-1H patient mortality. One benefit of ERT post-transplantation was reduced orthopedic complications in patients younger than age 8. This treatment is still not the most promising option because ERT still causes anti-drug antibody development in HSCT patients. Ultimately, this results in worsening outcomes post-transplantation. Due to the limitations of this combined treatment and its inability to reverse disease manifestations, research is needed for a new treatment that can reverse and correct all manifestations of MPS-1H.
Thanks, Emily. And she's exactly right, folks. A new potential treatment which might target all and reverse symptoms of Mpsi-H is hematopoietic stem and progenitor cell gene therapy, or HSPC for short. This therapy is producing promising results in research and may make HSCT and ERT a thing of the past.
Oh, I've read about this new HSPC gene therapy. I heard only a small amount of research has been performed. There are unknown long-term effects, and there's an increased risk for insertional DNA mutagenesis. I also heard that HSPC gene therapy can cause regimen-related toxicity, like HSCT.
That's right, Victoria. But before we jump to any wild conclusions, let's first look at how HSPC differs from HSCT and why it may be more effective in treating MPS-IH. As previously mentioned, HSCT is the transplantation of healthy donor HSCs, which are collected from bone marrow, peripheral blood, or umbilical cord blood to a patient with MPS-IH. Transplanted healthy donor cells then secrete enzymes into adjacent defective cells through endocytosis. However, many factors, such as the patient's age, disease stage, type of donor cells, and drug administration prior to and after transplantation affect HSCT's efficacy, not to mention the risk of graft versus host disease. In turn, HSPC gene therapy employs two primary transduction or delivery pathways, in vivo or ex vivo. In vivo gene therapy involves intravenous, intrathecal, or intraarticular injection of viral vectors to deliver genetic information to cells. Ex vivo gene transfer utilizes lentiviral vectors. Lentiviral vectors can insert, modify, or delete genes in organisms using the lentivirus. In HSPC gene therapy, lentiviral vectors are used to insert a patient's own modified autologous HSPCs into their DNA. Through transduction of a patient's own HSPCs with inactivating vectors carrying copies of a therapeutic gene, IDUA enzyme deficiency can be corrected. After reinfusion, genetically modified HSPCs divide and create progenitor cells, which pass the IDUA gene to daughter blood cells. This passing effectively alters gene expression in patients and prevents cardiac, orthopedic, or musculoskeletal complications, unlike allogenic HSCT and ERT. Please take a look at the picture on the screen depicting the methods and outstanding results of Bedone et al.'s study using HSPC in mice with Mpsi-H. In this study, mice infected with Mpsi-H underwent in vivo intra-articular HSPC in which the pIDUA plasmid, or the gene that encodes for IDUA expression, was injected into their bloodstream at the joint. After 2 days, researchers measured the levels of IDUA activity in specific locations throughout the mice's body, including synovial regions commonly affected by Mpsi-H. As you can see, the HSPC technique produced positive results across the board with significant markers in the orthopedic regions. Although this is only one study and it involved mice, these results point to the potential behind HSPC therapy and call for further research to be done. Also, a recent technique involving liver-directed gene transfer in mice showed that IDUA enzyme activity in the liver, peripheral tissues, and brain could be restored. This technique corrected brain pathology, improved cognitive impairment, and corrected orthopedic manifestations of Mpsi-H in mice. A liver-directed adeno-associated virus 8, or AAV8, modified with a brain-targeting peptide with IDUA, was used to evaluate and improve the BBB crossing ability of IDUA after secretion from the liver. Adeno-associated vectors, or AAVs, are transformed from naturally occurring viruses into delivery mechanisms for gene therapy by replacing IDUA-deficient genes. Hepatic targeting AAV vectors maintain high levels of therapeutic IDUA in the blood, helping IDUA reach inaccessible tissues. Results of the study showed that modified AAV8 in mice resulted in sustained supraphysiological levels of IDUA peripheral tissues, such as the heart, liver, spleen, lungs, and kidneys. Further, not only did GAG levels in mice decrease, but they returned to normal 16 weeks after treatment, demonstrating the ability of gene therapy to reverse Mpsi-H manifestations. This treatment also corrected bone abnormalities in mice at the femur and zygomatic arch. Ultimately, this research demonstrates gene therapy's ability to target musculoskeletal, neurocognitive, and somatic symptoms of Mpsi-H. It provides a promising path for the non-invasive reversal of Mpsi-H manifestations in peripheral tissues and the central nervous system.
Sure, so as you all can see, MPS1H is a lysosomal recessive disease that has major neurological and skeletal complications that drastically reduce the quality of life and cause premature death. It arises from the lysosome not producing enough IDUA enzyme to break down GAGs, leading to various neurological and physiological defects. When looking for an ideal treatment, we are trying to both delay the onset of further symptoms and revert any damage that has already been done. ERT has a few main drawbacks. ERT cannot reach the brain to address any neurological complications from MPS1H. Also, ERT has to be continuously administered, leading to a high cost, frequent hospital visits, and a significant burden on the patient. One of the other significant drawbacks is that long-term ERT therapy has a reduced effectiveness due to antibody accumulation in patients. These limitations make ERT insufficient on its own. Rather, it is used as a supporting treatment prior to and after allogenic HSCT to improve patient conditions and outcomes. Though HSCT can improve neurological symptoms of MPS1H, it has its limitations. HSCT fails to alleviate musculoskeletal, cardiac, and pulmonary symptoms. Also, it has a high variability of success between patients. There is a risk of graft versus host disease, and the preparative regimen for allogenic cells may cause regimen-related toxicity. Since HSCT and ERT individually have disadvantages, a newer method combines the treatments. This combined therapy aims to target neurological symptoms of MPS-1H by crossing the blood-brain barrier. Though this treatment is associated with better patient outcomes, it fails to address the patient's immune response and antibody accumulation post-transplantation. Gene therapy has been shown to correct and reverse most manifestations of MPS-1H in mice.
The advantages of
small amounts of
HSPC
research
in
have been
alleviating
performed,
cardiac,
and there
skeletal,
are
and
unknown
neurological
long-term
symptoms
effects.
over ERT and
HSPC
HSCT
gene therapy
far
also
outweigh
poses
its
an increased risk for insertional
HSPC
DNA
gene
mutagenesis
therapy may not be used as
and
a
may
clinical
cause
treatment
regimen-related
method for
MPS-1H
for years to come.
before applying this
But with more
treatment to
research
people,
and human
more
applications,
studies should be performed.
treatment for MPS-1H patients will radically improve. The advantages of HSPC far outweigh its complications in denying this as a promising treatment method. In HSPC, orthopedic defects, neurological symptoms, and IDUA expression are improved more than any other method. Autologous HSP gene therapy provides a long-lasting functional copy of the IDUA defective gene and reverses MPS-1H manifestations in mouse models. Therefore, developing HSPC gene therapeutics is essential to reducing morbidity and mortality associated with MPS-1H.